She has a long history of drug use. I think it started when she was 19, and she's had 4 C-sections, but she was given Tylox back then, and then Vicodin for migraines. She has used those nasally, and she's used IV heroin. That was her go-to. She would use benzos sometimes to come down from meth. So she's used almost everything, and alcohol was also a problem at one time. So her comorbidities are, she has a lot there: anxiety, depression, recently diagnosed with interstitial cystitis, chronic low back pain, GERD, insomnia. She's had iron deficiency anemia, irritable bowel, neuropathy in her lower extremities. She is perimenopausal right now. She has psoriasis and a vitamin D deficiency, and is still smoking. There you can see all of her meds. She was on methotrexate at one point for the psoriasis, but the dermatologist took her off of that until she gets through the hepatitis C treatment. So she is on meds for the irritable bowel, for her vitamin D deficiency. She's on mirtazapine for the depression, anxiety. She takes omeprazole for the GERD. You could see the other meds, quetiapine for sleep. And she seems quite anxious. She came in one day and brought a form that is used sometimes, I believe, by attorneys to help with disability. And when I started to ask her questions like, how long could you sit for a 4-hour period, sit at a job, like 1 hour, 2 hours, 3 hours, and she just could not handle that. And she said, if I have to do that form, I'll just go find me a job. But she's, as our relationship has developed over the past 6 months, it seems like she is more comfortable around me. So she is immune to Hep A and Hep B. And there you see her weight and height. She is obese. We've got her hemoglobin up to 14.7. Creatinine 0.9, glucose was 102. Her pro time was 10.2, INR 1. Liver, her ALT 69, AST 43. And you see her APRI is 0.513. Child Turco is class A. Score was 5, and a MELD score of 6. Here's her iron levels. We've had a time getting her vitamin D level up. Her insurance card will pay for D2, and it seems like that is slower to raise the vitamin D level than vitamin D3. Her genotype was 1A, and her viral load 382,000. Fibrosis marker 0.12. Her rheumatoid factor was 27.2. And again, that is something that hopefully will come down after she is treated. Cryoglobulin was none. Hep B core was negative. So I said that the treatment could be Mavorite or Epclusa. I think that I would personally go with Maveret if possible, because I think the least amount of time with her taking medications would be better for her. And so I'm open to suggestions.
Thank you so much, Tammy. That was a wonderful case presentation. Before we jump into any of the case recommendations and feedback, did anyone have any clarifying questions or questions for Tammy? Feel free to unmute or chat in. All right, and any feedback from any of the hub members?
Can you hear me?
Yes,
Okay.
we
Okay.
can.
Sorry. Hey, Tammy, John, Philfoos, and just a couple quick comments. Thank you for doing the fibrosis markers in addition to the APRI. You can see there was a discordance there. Had we only looked at the APRI, we might think this patient was someone who wouldn't need long-term HCC screening, but the serum fibrosis markers suggest F3. So even after you treat this lady and cure her, she will need every 6-month screening ultrasound, sort of long-term. Treatment options for genotype 1A. Just a couple things to mention. I agree with you, Maveret, 8 weeks, or Epclusa for 12 weeks are options. Remember, if you did decide to use Zepatir, you'd need to do the NS5A polymorphism testing that would dictate whether or not the patient would get 12 versus 16 weeks. So Zepatir is an option, but a bit more complicated to use. And lastly, Harvoni. Harvoni, I just want to mention for a second, the patient does have genotype 1 and non-cirrhotic and a viral load less than 6 million and HIV negative. So classically, there was another factor that would prevent us from using short course of Harvoni, and that's the fact that she's African American. And that was true from about 2014 to 15. I can't remember exactly when Harvoni came out, until 2018. So depending upon what guidelines you read, you might read that if your patient is of African American descent, that you cannot give short course Harvoni, that you have to give 12 weeks. Well, it turned out in a study in 2018 out of Kaiser Permanente in California that is not true. Patients who are African American and otherwise meet criteria for short course Harvoni, and again, just to reiterate, those are patients who are treatment naive, no cirrhosis, HIV uninfected, and a viral load less than 6 million, can go ahead and get short course Harvoni. So long roundabout explanation for saying Harvoni would be an option at short course of 8 weeks. You know, the issue with Harvoni and Epclusa in this patient is acid suppression. Ideally, you'd like a good acidic environment for those drugs, and the patient's on some medicine to suppress those. So I still think Maveret's your best choice. I didn't do the drug interactions myself, but I don't eyeball test, see anything majorly glaring there. And the last, I think you had the question on this one. Was this the one where you said, do you have to redocument viral load in 6 months or something like that? I don't think you do for Medicare. I think that's a Medicaid thing, but I defer that to Kaylee or someone else who knows better than me.
Thank you so much, Dr. Gilfus. And I'm more than happy to pull up the case again if anyone would like to refer back to Tammy's questions. Were there any other comments or thoughts from anyone?
Hey, Tammy, it's Kaylee. Just clarify, because with the fibrosis marker that you have listed just as 0.12, can you pull that up and see what the interpretation was, what staging? Since we have kind of different scales sometimes, I just want to make sure.
All right. Let's see. Now here mine says F0.
I think I'm looking at the other case, sorry.
Oh, okay. Yeah.
No worries. That's why I just wanted to double check so that we weren't doing ongoing ultrasounds if needed. If she I agree completely with Dr. Gilfus's management plan about you either could do Mavorite like you suggested would be fine, and the other option would have been the Epclusa, because those are the two that are covered on her insurance. The Epclusa would interact with that omeprazole that she's on, but otherwise it doesn't seem like there's any drug interaction. So probably going with Mavorite. And honestly, Tammy, just counseling her, I mean, it sounds like just from my assumption that the real reason she's seeking treatment right now is so that she can restart the methotrexate. Is that what it is for her psoriasis, or is it more that she's just feels that she's in a good place for?
No, I really didn't get that impression. I think that it's just that she's in a better place and she's not used. Yeah.
Okay. And I think just because I guess the only other thing that just to consider, since she's at the mission, unless she's getting, going to have any, I should say, more secure housing in the future, is sometimes when I have patients that are at a mission or that they're in a transient living situation, that the medication just gets dispensed to your office.
Mm-hmm.
And then that way you're following with her and she's coming in. And so you get to lay eyes on her more quickly. Plus, that she's getting the medication, but also that it's kind of a secure location for her to receive it, because it's really hard to dispense it to the homeless shelters a lot of times. But we've been definitely successful with, if she's agreeable to it, to just having it dispensed to the clinic and her coming in, once a week or even once a month if that's too difficult for her to come in weekly. Just so that way you're keeping her in close care during that process. But she, the only other thing I would consider, I mean, I don't necessarily feel strongly about it because her fibrosis marker was consistent with F0. But just remember, in our obese patients, we don't get as good of a fibrosis assessment because of that, if they have that truncal obesity. Now, I mean, her ultrasound, it looks like, just showed fatty replacements and enlarged liver, and that honestly is probably from the Hep C, maybe also from the obesity as well. But if you had somebody that had a more advanced fibrosis score, so if she was F3 or F4, you may want to consider with the Hep C, HCC surveillance screenings, getting an MRI at some point so you get a more thorough liver assessment. In her, not so much, since she didn't have any evidence of advanced fibrosis, but just kind of for the group to keep that on your radar as well, that an ultrasound sometimes isn't going to be as specific for HCC with our obese patients. But great. Thank you so much for presenting her, Tammy. I appreciate it.
Mm-hmm. Thank you for your feedback. Thank you, John.
Were there any other thoughts or comments from the group? And Tammy, were there any other questions you had about your case that you wanted to ask the group?
Let's see, I don't think so. I think you all covered it.
Oh, that's wonderful. Thank you so much again for presenting that case. And thank you, Dr. Gilfus and Kaylee, for the feedback. All right, so I will share my screen. Robin, I'll turn things over to you anytime you're ready, and just let me know when you'd like me to scroll up or down.
So the patient that I have that we're trying to treat now, she's 71 years old, a Black female who she came into the clinic just trying to establish a new PCP. After she was diagnosed through a local community program with hepatitis C. However, she's been seeing a GI doctor for a while because of already diagnosed cirrhosis. And what I can't understand is why they've never checked a hepatitis panel on her. And I actually got a recent note from their office, and they don't have hepatitis C as a diagnosis. So I'm not sure about that. I still need to touch base with her GI doctor. I do know they're not treating her. So she does not know how she got it. She has no idea. She does have a history of cocaine use a long time ago. Her husband apparently has several relationships going on, so she thinks she might have got it from him, but she's not sure. Right now she does smoke marijuana, but that's the only thing that she uses right now. So her comorbidities, she has hypertension, diagnosed cirrhosis, anxiety, diabetes, and vitamin D deficiency. She does have several, she also has HCV. She sees several specialists for her multiple conditions. Her last A1C was 9, so it's not super controlled, but it's better than, I guess, some. As far as her labs go, her white blood cell count, 6.3, hemoglobin, 13.6. I'll just, touch on the significant ones. Her platelets were 202. Her glucose, actually, when we did it in the office, was 279, which is probably a typical level for her. I'm sorry, I'm going out of order, aren't I? Sorry. Her APRI score was 0.507, and her MELD score was 8. Her iron studies show an iron of 58 and a ferritin 59. Vitamin D is within a normal range. She is negative for HIV. Her Hep C genotype is 1A. Her viral load was 3,210,000 with a fibrosis score of F3. She has a pacemaker, so at her GI office, they could not do a fibro scan. They do have one in their office, but they can't do that because of her pacemaker. So the issue with this lady is she has Medicare and Medicaid. So will I have to wait the entire 6 months since she has Medicaid to prove that she's had it long-term? Because it's certain that she has, but will I have to wait? And I'm assuming that when I do get to treat her, Mavorip would be the best option for her for 8 weeks.
Thank you so much, Robin, for that case presentation. We really appreciate it. Did anyone have any clarifying questions for Robin before we get into the feedback and recommendations? All right, and any hub members with recommendations for Robin?
Hey, Robin, it's Kaylee. I'm sorry. I wanted to clarify a little bit better too, because it says she had cirrhosis of the liver. How was she diagnosed with cirrhosis?
She is kind of a poor historian, and so I think she's been seeing Dr. Patel. He's a local GI for a long time, and he diagnosed her in the past. She was seeing him for diverticulitis. And so she's had some ultrasounds, and that's how it was originally diagnosed, with these ultrasounds. However, I'm still confused as to how they did not, or why they didn't go ahead and do hepatitis C testing, because he does treat hepatitis C through his office. We had referred to him in the past. So I'm not certain about that, but that's how she was diagnosed, is during the treatment for the diverticulitis.
Thank you. I appreciate that. I just, yeah, and typically with the even with the pacemaker, they can still do the fibro scan because it's just an ultrasound, which is confusing to me too.
They put that in their note that they couldn't. Is why I said
that. I'm not sure what I don't know what the deal is with that, but no. What we could as far as management options, it honestly, as far as your kind of scope of management options, would be the same as with the last case, which Dr. Gilfus gave a great explanation of what the options are. But you have Mavorip times 8 weeks, Epclusa times 12, Harvoni. It really is dependent on a number of factors, whether it's the 8 week course or the 12-week course, and then the Zepatier times 12 weeks. Now, with kind of the next kind of step I think about when I have all my options available is I look at drug interactions, I look at what insurance is going to cover, cirrhosis status to see if you're able to do kind of a shorter course, what's going to be most feasible for the patient. And so the next thing I would try to find out, since she has Medicare and Medicaid, is if she has a Medicare Part D plan. Since that would be the prescription drug coverage, would be the Part D. If she doesn't have a Part D plan and she has, then Medicaid would pay for the Hep C drugs. And if that's the case, then unfortunately you would have to wait for that 6 months.
Okay.
Now, if she does have a Medicare Part D plan, they may have a different formulary or preferred regimens than the Medicaid, which just is covering the Mavorite and Epclusa. But typically, and Rachel can correct me if I'm wrong, but typically with Medicare Part, they're not going to do that requirement of 6 months. And especially if she has evidence of advanced liver disease, they won't, they won't want to have you delay getting treatment initiated unless certainly she was decompensated, which that doesn't sound like. So, I mean, my go-tos are typically the Mavorite and Epclusa because those are typically what are the preferred agents. But I would find out first if she has a Part D plan, and if so, what are the preferred agents on that, since that's kind of her primary insurance.
She does? So she's got Part D. Okay, she does have Part D.
Okay, great. So then, honestly, there's a couple options then. Either, one of your staff could help to see what the preferred agent is on her plan,
Okay.
because it might be Harvoni, it might be Epclusa or Zepatier, but not just Mavorite, and then find that out first. And then, or like I said, our specialty pharmacy, Allied Health, they're wonderful. They help out so much. They've been willing, if I just say, hey, this is what my patient's insurance is, then they are able to run a claim, or not a claim, but they're able to look in their system and see what preferred agents are there. So you have a couple things to help out, so you don't have to take your time up to contact them. But as far as the drug interactions too, that's something I'll have Rachel speak on because she's on so many different meds. It seems like Mavorite would be the best option for her, but I'll make sure that Rachel gives input on that, so I'm not wrong.
Kaylee, I'm not sure if Rachel's on the call today.
Oh, crap. Okay. Oh, darn it. Rachel, why isn't she on the call? Yeah, I know. I was actually just pulling it up. Darn it. Okay. Well, you know what? We'll just try to see, Robin, if we can figure out, what those preferred agents are, and then going from that, run a drug interaction report. So to try to make sure,
because we looked it up just now, or my nurse looked it up just
Yay!
now.
Bomb.com. Awesome. You guys are so quick. I love it. So,
not me, it's my staff.
But it's great to have good staff, to have excellent staff that works with you. Yeah, so with her, then I would do Mavorite times 8 weeks.
Okay.
And she would have to take that with food, would be just something to let her know. But I really don't think you're going to have that same hard stop of having to follow the viral load for 6 months, even though she's a new diagnosis. I mean, my gosh, this lady's in her 70s and has multiple comorbids. So if she's wanting to get treated, and I don't think that's something to delay on her.
Okay, great. All right.
Thank you.
Thanks.
Thank you all so much. Were there any other questions for Robin or about the case from anyone in the group? Feel free to chat in or unmute. All right, and Robin, were those all the questions you had about the case as well, or was there anything else you wanted to have addressed?
I don't think there's anything else that I need at this time.
Okay, no, that's wonderful. Thank you so much again for presenting that. We really appreciate it. All righty, so Jared, I'll turn things over to you for the didactic portion. Do you want to share your screen, or shall I pull it up on my end? Whatever
if
you
I can
prefer.
share, that would be great.
Okay, absolutely. Let me give you that ability. Okay, you should be able to do it now. Let me know if there's any trouble.
Okay, looks like it's up on my screen. Like every good presentation, I see you shaking your head that everybody can see the presentation, right? Okay, perfect. So I'm Jared Coffey. I'm the HIV prevention medical scientist with Gilead. And we're going to switch gears a little bit from Hep C and talk about PrEP, and really talking about TelePrEP. And this came from a discussion I had with Kaylee in the beginning of the summer. And she is, we were talking about PrEP at at her practice, and she was saying that TelePrEP, that she was doing quite a bit of it, and I was really intrigued by that. And she just wanted to see if I could do a little presentation on TelePrEP implementation. And really, this is very general. There's no talk about drugs with this presentation. And really, if you have any questions, the thing that I think that is great about COVID, which I don't think there's anything much to say that's great about COVID, but the rise of telemedicine and TelePrEP as well. I will apologize if you can hear some banging and stuff. We're getting a fence put in our new house right now. So there's a lot of commotion outside. This information is not promotional, and the double dagger symbol signifies that. So really thinking about COVID-19, we're going to talk about COVID and HIV quite a bit through this presentation, because we threw this presentation together as quickly as possible just because of COVID, and really thinking about a tale of two pandemics. And really these heat maps really show that COVID and HIV, they really overlap. And a significant overlap could be because of the long-standing health disparities in the areas that are listed here. Just to point out the Ending the HIV Epidemic Plan, if you haven't heard of that, it's a plan that we want to end HIV by 2030. So this plan was originally supposed to start in 2020. Something happened in 2020 that may have pushed us back a little bit because of COVID. But the goal is to have a 75% reduction in new HIV infections in 5 years, so by 2025, and 90% reduction in 10 years, so by 2030. There are 4 different pillars. We want to diagnose, we want to treat our patients, so treatment is prevention. We want to prevent, which is where I come in with HIV prevention, and syringe service programs, which we will not touch on that taboo topic in West Virginia today. And we want to respond to potential HIV outbreaks as quickly as possible. West Virginia did not have to create a plan, but if you think about the 3 Cs in Ohio, Columbus, Cincinnati, and Cleveland, had to create a plan. If you look just to the east of West Virginia, there are some plans that had to be created. And West Virginia was a state of high rural burden HIV that had to create a plan as well. So really focusing on ending the HIV epidemic, but understanding that a lot of talks are happening in Tennessee and in West Virginia, I've heard as well. We want to end the syndemic of viral hepatitis, HIV, and substance use disorder, because they really all do play a role and are linked together. The United States Prevention Services Task Force gave a grade A recommendation last January for PrEP. So the grade A recommendation means that they concluded with high certainty that there's a substantial benefit to using PrEP to decrease the risk of HIV infection in persons at high risk of HIV acquisition. So those persons at high risk of HIV acquisition, they recommend with a grade A recommendation to offer PrEP. And some additional guidance has come out as of July, because there's been debate on, okay, we're supposed to offer PrEP and they're supposed to cover PrEP, but is it PrEP, the medication, or is the ancillary lab work, doctor visits? And they came out in July saying it's everything, and they have 60 days to implement that. So that's really good news for our patients. So thinking about the impact of COVID-19 on sexual behaviors among MSM. And this is some information that was looking at an online survey of gay, bisexual, and other MSM with men's experience of sex and HIV prevention during the COVID-19 epidemic. So this is just looking at from February to May of 2020, just to put it into perspective. So 1/3 of participants reported that COVID-19 impeded HIV or STI testing despite high willingness to test. We know that a lot of practices shut down. How are we trying to figure out what do we even do to maintain the practice in the light of COVID? PrEP use in the prior 3 months prior to the study was 27%. And with the current PrEP use at the time of study, so February to May, was 18%. So we could see it decreased. But there were mean increases of 2.3 sex partners and a mean increase of 2.1 anal sex partners. So thinking about that as well. 1/3 of respondents reported an increase in binge drinking or substance use disorder, which we know could decrease inhibitions, leading to decreased judgment, I guess, and perhaps increased condomless sex. So what we can see is, despite the perceived risk for COVID transmission during sexual encounters, respondents showed only moderate willingness to change their sexual behavior. sometimes really thinking that what else is there to do? I'm stuck at home, I'm in quarantine. And there's a clear need for continued provision of comprehensive HIV prevention and care services during COVID-19. And really, like, I was thinking when I was reviewing this presentation, like, oh, this was in the peak, so the spring of 2020. But you know what, like, we're riding waves with COVID-19 and going like in and out of like should we be masking? Should we be sheltering in place a little more? So I think that this is still really relevant. Brawley et al. Presented at AIDS 2020, and this is looking at the impact of COVID-19 shelter-in-place orders on PrEP access, usage, and HIV risk in the United States. They looked at PrEP users and providers, but just a couple things. 33% of participants reported discontinuing PrEP. So it means that 2/3 stayed on, but those that discontinued, it was mostly due to a low perceived HIV risk. And I think that that's always something that we need to be doing, is helping our patients understand what their risk is and why they would benefit from PrEP and maintaining being on PrEP. And 10 to 12 respondents reported similar or more risk behaviors post shelter in place. And looking at the providers, the one thing I'd like to point out is in this graph is, did providers have post shelter in place prescribing deviations? And 59% said yes, and the refills were done via telemedicine. So really showing like the rise of telemedicine during this time. Haley, I know that you have to dodge out at 1 o'clock. Do you want to say anything about how TelePrEP is going for you before you dodge out? Because I know that your opinion would be greatly appreciated and your perspective.
Yeah, thank you so much, Jared. I thanks so much for presenting today. I really appreciate you coming in and giving such good data and such good insight. And Jared's a great resource if anybody is interested in. I'm putting him out there, but if anybody's interested in learning more about PrEP, he totally is. He's super responsive. You know, in my clinic, PrEP has been a huge, TelePrEP has been really paramount, because it's really gotten people into care that I should say in a more expedited manner than if they're trying to see me in person. And a lot of times it's a partner that I have within, you know, our HIV clinic that's interested in TelePrEP, and I can't necessarily see him on the same day. So we just schedule a phone visit for the next coming days, and then they're able to come in and get their labs and their testing and whatnot. But you know, one thing, just as Jared was saying, is that the discontinuation of PrEP, from my standpoint, I've had not as many patients. I really haven't had anybody stop PrEP during the pandemic, but I will say that the way my group might differ from the providers that are on the call is that I have patients that are coming to me wanting to find somebody that's willing to prescribe PrEP, because they don't have a primary care that knows anything about it. And so my patients are I'm not seeking them out. They're very motivated to be on PrEP, to stay on PrEP. Their adherence is excellent. And so as you know, I do challenge with our primary providers that are on the call, you may have a little bit of a different perspective with, you know, trying to identify those that would benefit from PrEP and then not being able to keep them in care. It's a little bit different when you're, you know, trying to seek them out and they don't have that perceived risk than those that are coming to me specifically asking for it. But it does help a lot. You know, I will say of the patients that I have on it, it has been a lot easier for them to just do a phone call or a video visit to check in and see how they're doing. And then I just put standing orders in and they get their labs as they need to. And then I just write for it, and they don't necessarily have to come into the office maybe twice a year. So it does help. But if you guys have any questions at all before I hop up, off specifically for me, please ask.
Thanks, Kaylee. Appreciate that. So as we move on, during the COVID-19, during the beginning of it, the CDC in May released a Dear Colleague letter that really was saying that there was just guidance on PrEP during COVID. We need to still think about reducing the number of HIV infections, and PrEP care is essential. Fauci said it before the pandemic, and Fauci has said it in June just again, that we are still on track to end this epidemic, and we can do that with the help of PrEP. Quarterly HIV testing, preferably, or potentially even lab-only visits. As Kaylee said, she has some standing order labs that she can send. There's the potential for home specimen collection, the kits that can be done. I think molecular genetic labs has a kit that's available that can do HIV and STI kits at home. Last resort would be the oral HIV swab at home as well, but really trying to be sure to keep our patients on. And, we want to confirm our patient's HIV negative status. Consider a 90-day supply with prescriptions. I think that that's something that may be overlooked sometimes, but that can decrease the amount of visits a patient needs to have to a pharmacy, or the amount of contacts if a patient is worried about going out. A pharmacist is typically able to switch from a 90-day supply to a 30-day supply without a provider's approval, but sometimes it can be a little more difficult to go from a 30-day supply to a 90-day supply, and that's all state specific. So thinking about a 90-day supply, and if insurance covers it, the pharmacy can definitely do that. And then understanding the different resources that are available. So Ready, Set, Prep, the Gilead Advancing Access Program that can cover up to $7,200 a year for our insured patients, or those patients that are uninsured, they can help with the patient assistance program as well. So lots of things to consider with telehealth. It can be convenient for our patients. It can be convenient for our providers too. A lot of providers may be thinking that, I have some providers in Columbus that I work with that they have telehealth days and that they can work from home, which they never thought could happen before. There's increased access, savings to the patient. Maybe it's a lot of our patients may be hourly employees. So allowing them to not have to take a full day off work. Maybe they can do this on their 15-minute break or their 30-minute lunch, and they don't have to take any time off, and maybe decreasing stigma that way as well, because they don't have to take a half a day to go to the doctor's appointment. You're like, oh, you're going to another doctor's appointment every 3 months? What's going on? Are you okay? So thinking about it that way. Sometimes the appointments are faster. The patient confidentiality can go both ways. So a patient may feel better and less stigmatized doing it at home on their own time. However, we also have to think, does the patient have a private place that they can actually have these conversations that the provider needs to have with them? There can be increased persistence and increased retention. And it really is a case-by-case basis with each patient, how that may work. And I can't see the chat. I'm sorry. If anybody has any questions, interrupt me, please. Telehealth, what is it? So many different things could go into what telehealth is. But really thinking there's different telehealth techniques. There's the synchronous. This is probably the most common. It's a real time. It's a phone call. It's a video call with a patient. There's the asynchronous, where you can store and forward technology to review later, and remote patient monitoring as well. But really, the synchronous is the most common. And it can look in completely different ways. So this could be the patient to the provider. It could be provider to provider to get, I know that we're doing things here in a virtual aspect, and really thinking about that. A patient to the case manager or the PrEP navigator to help them navigate the systems. The location with internet access, that can be a barrier. And I brought it up with Kaylee. If there was a digital divide with the patients that she's servicing, especially thinking about broadband access in rural areas. And she said she's not having that, which I was very shocked and pleased to hear. But I have some organizations that they have like little satellite places set up. A patient can go to a local affiliate of the health system, and they can see a provider in a room with that. So it could be at home, it could be at a clinic, it could be at the hospital. With different devices a patient may need: smartphone, computer, tablet, monitoring device. My mom is elderly, and she doesn't really do well with the video visit, but she does very well with phone visits, and we did quite a few of those during COVID-19. She had quite a few health problems. So we need to understand who your audience is, and who your patients are. Where are they coming from? So who are you wanting to serve? Why would you want to provide telehealth? And maybe it's just that you are maybe able to deliver care when an in-person visit isn't possible, or really trying to just partner with that patient to meet them where they are. Where are your referrals coming from? Can be really interesting as well. Maybe a patient, maybe they live in a rural area and maybe they don't feel comfortable letting the provider know like why they would benefit from PrEP, and maybe they're going to seek care at a different area of West Virginia. So understanding where they're coming from and making it more convenient for them. Bias, what is your bias? What bias does your organization possibly hold regarding telehealth? But when I talk about bias, what always comes to mind is I have a provider that was saying that he didn't realize what bias he had toward his patients, seeing them in their natural habitat, where they live. If they're having an appointment at their home, he was having a conversation with a patient about diabetes and hypertension and cholesterol, and they're sitting in a recliner smoking a cigarette because they're doing a telehealth visit. So it's just the bias that may come along with that. And can telehealth deliver care to those who struggle with regular visits? So like what we mentioned, meeting the patient where they are. Patients may have some questions. What services can I do with telehealth? Will my insurance cover it? Most of them have been on parity. Hopefully that will maintain, but we don't know. It's a to be determined kind of aspect. Will I need any equipment, which we spoke about the different equipment that can be before. Is it safe? So really doing it in a safe environment, using the health system platforms that are available. What do I do if I don't have stable internet at home? Like maybe we just do a telehealth or a telephone visit, and like the length of the visits, which a lot of times are typically shorter. If you're going to develop a telehealth website, you may create a distinct telehealth section just so that the patients may know it's available. Make the access to these services as easy as possible. So they found that like 3 clicks or less is better for patients, especially those that may not be as tech savvy. And maybe ensuring all the forms are available there, and allow the patients to directly schedule a telehealth appointment online. I know with like, if I'm going to my doctor, I don't call anybody anymore. I make my appointment on my chart. It's very convenient. And if that is an option for some patients. And then there's your capabilities if you have the capability of a patient portal. So you can, all the different things that come with the patient portal as well. And I'm just referencing my chart because that's what Ohio Health has that I use as my primary care provider. So how do we implement it? And I think Haley mentioned a few things, like with the PrEP initiation appointment, that you could have a patient come in for their first appointment in person, and then from then on, it could be an expectation after you explain what the process would be for a telehealth visit thereafter. Or there are some programs, there's NERCS or NewRx, Mr. Sister, Plush Care, they offer PrEP just solely via telemedicine. Labs can come to mind as to how are we going to get labs done. So those can be live, like Kaylee said that she offers the standing orders, but you could use a third party. So thinking about LabCorp and Quest, or even the mail order, like we talked about, Molecular Genetics having their at-home test kit that's available. And then receipt of medication, a pharmacy pickup, or maybe remembering to do that 90-day supply. We're even thinking about a pharmacy that may be able to deliver to the patient as well. With thinking about the best practices. So linking that patient, a lot of patients that enter into PrEP, they may be younger. They may not have even thought about a primary care provider before, but maybe this is their entry into care. And so many, we were talking about Hep C quite often on these calls, and maybe just thinking about the overall health and treating the patient holistically. The labs to order, we have the required labs, so that we want to know that HIV status immediately prior to initiating, and every 3 months. We want to be sure that patients maintaining that negative status. We want to know their hepatitis B virus status, because both oral agents have activity against Hep B, and we want to know their creatinine clearance, their renal function. But then the recommended ones as well is hepatitis C, and then any site that a patient's using for sex, we want to be able to test that for STIs. Linking a patient to the medication assistance programs. Coming from the specialty pharmacy aspect, I can say that the Advancing Access program was very user-friendly and easy to use online. And then you can also link that PrEP patient to other services or providers, including housing, food, and employment. Lab tests, we kind of talked about this a little bit. This is like the tricky part. It really is just dependent. There are some places like that do in-house where they may send a patient a lab kit to do and have the patient send it back to the house or to the practice where they would batch it and send it to the lab. You could do the third party. You could work with Quest or LabCorp or even those things that are mailed to the patient. Many different ways to think about lab work. Really is state specific and what's available to the patient and available to your area. If you are going to do these self swabs, maybe really important to send the patient instructions. I have some providers that have tried to use Quest and LabCorp to maybe hand the patient a self swab and then collect it, but LabCorp would not do anything with counseling the patient. So being sure the patient has the information on this is what you're going to have to do. You're going to have to swab your throat. You're going to have to swab, the every site that you test and with the instructions so they know exactly what to do. There's no concern or question. And Kaylee pointed out too, like partnerships. And I think this is truly important. So knowing the partnerships go both ways. So if you're going to offer telemedicine and TelePrEP or just PrEP in general, work with your health department so they know that you're a provider. And then that way, if the health department has any patients that are seeking it, they can reach out. Working with specialty pharmacies or pharmacies in general too, to know the importance, maybe to be sure they keep it in stock, maybe to know that the different plans that a patient shouldn't have a copay and that there are so many plans that are available to help the patient. Pharmacies can also help with compliance. Specialty pharmacies typically call the patient to see how they're doing, any missed doses, and they can relay that information to the provider. But just really working together and having these partnerships and substance use and other specialty care, I think is really important to point out in West Virginia as well, because it's kind of ending that syndemic if we think about it that way. There are barriers that have been identified to PrEP, and TelePrEP may help to address some of those. So what if a patient doesn't have a car, or the stigma about going to a specific practice? Well, you can do an appointment from home, and that may really help. The work schedule, which could maybe lead to missed money. And there's so many different things, but it really is just focusing with the patient that's sitting in front of you or on the phone with you and understanding exactly how you can help them the best. Stigma can affect people at risk of acquiring HIV and or using PrEP. Anticipated sexual risk compensation with PrEP can lead to PrEP stigma and may consequently reduce the willingness of healthcare providers to prescribe PrEP, shift individuals' perceptions of their own eligibility or need for PrEP. And we kind of talked about that or alluded to that a bit, and helping the patient understand why they would benefit and what their risks may be. It can also reduce the motivation for at-risk groups to use PrEP and potentially reimbursement of PrEP. So PrEP stigma is important and really important to keep that in mind whenever you're speaking to patients. Rules and regulations, of course, we have to think about these with billing, licensure, and malpractice. And this is evolving, as we said, like we were thrown into COVID, of course. And but because of that, we had to figure out telemedicine. With licensure, thinking about providers must be licensed to practice in the state where the telehealth is offered. And certain states require special licenses specific to telemedicine, which West Virginia is not one of those listed below. Provider must ensure that their malpractice insurance covers telehealth. And with the regulations, all 50 states regulate and reimburse differently. So it is important to figure out exactly what's going on with West Virginia. And I'm sure Kaylee has a lot of information she can share about that. Like I said, this was quick. It was just a really high level presentation just to start the conversation about telemedicine and TelePrEP. But COVID-19 catapulted healthcare into the telemedicine and telehealth modalities. The CDC's offered some best practices. We need to consider innovative testing and lab strategies. And I had a provider just the other day say, why have these lab organizations not come out with at-home like complete packages to use and make that more available? And hopefully that will happen down the line. Consider that 90-day prescription for a patient. You can adapt telehealth model that fits best into the services that you provide, but also whatever fits best for what the patient needs. And consider the different rules that are available. And consider the overall benefits, limitations of continuing TelePrEP after COVID-19, which I think a lot of people are doing, and Kaylee definitely is doing that. And this could potentially impact the health disparities and access among individuals at risk. So really meeting the patient where they are. And that's it. Any questions? I didn't know if I was going to be able to get through it. I'm so windy and long-winded.
Thank you so much. That was so wonderful. With Project Echo, we were so used to like telehealth and Zoom calls even before COVID. So it's really interesting to see how telehealth is incorporated in other ways, especially for something like PrEP. So we really appreciate you presenting on that today. And you did a wonderful job with time-wise too. So awesome job. Were there any questions for Jared from the group? Feel free to unmute or chat in.
I'm putting my email in the chat as well. If you have any questions or need anything, like I'm really here to support. I have made it to Charleston once. So I joined Gilead January 2020. Great time to make a career change from pharmacy. So I joined it in the realm of COVID. So really have met everybody via Zoom. I call it Zoom jail. But started traveling in May and I made it to Charleston once. So I'm looking forward to meeting more folk in West Virginia.
Oh, that's awesome. Yeah, what a time to join a new place, right? In the peak of COVID, the start of COVID. But thank you for adding your email in the chat as well. And I'll be sure to attach your didactic presentation in the recap email that I send out.
Thank you.
Anything from the group before we end the session? We do still have a few minutes here. All righty. Thank you so much, Jared, for the presentation, and Tammy for the case, and Robin for the case. We really appreciate you all joining today and really making the session so wonderful. And it's because of you all, so we truly appreciate it. The only announcement that I have is that our next session will be on September 9th, and Dr. Feinberg will be providing the didactic. More information to come on the topic of the didactic, but keep an eye out for that reminder. And if there are any questions after the fact for Jared or any of us with Project Echo, feel free to always reach out via email. We're always happy to help. So thank you all so much, and we'll see you guys next time.
Thank you, Jared. That was excellent.
Thank you. Bye.
Thank you all.